So we will just discuss the novel biomarkers of acute kidney injury and chronic kidney injury today. Okay. So I will just mention the biomarkers and just some important points that you have to that you can know. Yes, it's good to know. Right. So you may also use these as one of your if you want to do some study for your journal or thesis, you can very well take up these markers. Okay. So first is these are all there are many markers. Okay, previously for any acute kidney injury or CKD, the kidney function test is always going to be urea and creatinine. Yes, so in spite of that, we will in addition to that you have the clearance tests. So you will have inulin clearance, creatinine clearance, urea clearance. So creatinine clearance was what we used. But nowadays you have other markers also which are being in use, that is cystatin clearance, serum cystatin levels, they're all being in use. So nowadays they have started using those markers. So we will see some of the markers here. So first marker is NGAL. Okay, first marker is NGAL, which is neutrophil gelatinase associated lipocalin. Yes. So here, yes, this is actually a growth and differentiation factor in all the nucleated cells, and it also helps in the iron trafficking in renal epithelium. So this is the use of this NGAL in the system, in the kidney, and basically this gets elevated in case of ischemia and nephrotoxic acute kidney injury. So in these cases you will find this marker to get elevated. It's detected both in urine and plasma. And where is it synthesized? It is synthesized in the loop of Henle and the intercalated cells of your collected tubules. So here, if you see, it is an early. It is actually used for three purposes. One is it is an early marker. Okay, so it starts to increase less than 3 hours of the onset of the ischemia and the nephrotoxicity, and it peaks by about 6 to 12 hours, and it stays for about 5 days. So this is one use. Next is in differentiating acute tubular necrosis from other causes like your hepatorenal syndrome. So kidney cause from other cause, and also it is used in the prediction of progression of any disease. So you can use it in prognosis. So this is the use of NGAL. So recently NGAL, it's been researched in many papers. Okay, so it's an ongoing marker. It's a novel marker. So you have other markers also. We will just see what are those other markers. One is interleukin 8. So second one is interleukin 8. Interleukin 8, the limitation, first of all, let's see. The limitation is, of course, it's an inflammatory marker. And in any renal parenchymal injury, this gets elevated. It's produced by proximal tubules, and it also peaks by 12 hours. So that is what is this thing of interleukin 8. But it's the limitation is also there, so which we need to interpret with caution. Another marker is kidney injury molecule 1, that is KIM1 protein. It's actually a transmembrane protein. Okay, in the membrane, it's a transmembrane protein that is associated extracellular mucin and immunoglobulin domain. So this is the structure of this KIM molecule, and this increases post ischemic injury, and this also shows early elevation. Next marker is liver type fatty acid binding protein. It is mainly produced by the renal cortex by proximal tubules. And if you see after post cardiac surgery, there can be development of acute kidney injury. So for those cases, this molecule is helpful. And this is induced by hypoxia. So after a transplant, if the kidney has undergone hypoxia, kidney hypoxia can be earlier detected by this marker. Okay, so this is the one uniqueness of this marker. Next is urine IGF binding protein 7, that is insulin like growth factor binding protein 7, and tissue inhibitor of MP2. So so suppose if there is sepsis and ischemia. Okay. Yes, tissue inhibitor of metalloproteinases 2. Okay, TIMP2. So that's how it's written. HIM2. Okay, so in this actually in sepsis or ischemia, what happens? There is a brief period of cell cycle arrest that the kidney undergoes, and this is induced by these two molecules. So this is an inducer of G1 cell cycle arrest. So basically, this is also involved in the pathology of the disease. So not just it can be used as a marker, it is also involved in the pathology of the disease. So urine markers are more specific. Urine markers are more specific than the serum markers. Next is calprotectin. Okay, calprotectin, this is associated with the cytoskeleton and this is produced by the immune cells. Yes, calprotectin is produced by immune cells and less than 2 hours it starts to raise and it peaks by about 48 hours. So with this molecule we'll be able to differentiate whether it's a pre-renal AKI or renal AKI. Okay, that is intrinsic or the renal AKI. So that's what we can differentiate. Next is urine angiotensin. Another marker is urine angiotensin. So what is this angiotensin? The function of angiotensin? Sorry, a urine angiotensinogen. Okay, so renin is something that converts this angiotensinogen to angiotensin 1. That's where we had learned about angiotensinogen, right? So when does this angiotensinogen gets excreted in the urine? So yes. So this is increased in acute decompensated heart failure associated acute kidney injury. So when acute kidney injury is due to any decompensated heart failure, then in those cases you find this to be elevated in the urine, right? So this is one thing. Next marker is urine microRNA. So this is an endogenous non-coding RNA. MicroRNA is a non-coding RNA. So microRNA 21 here, it increases earlier than the creatinine levels. Okay. So in very sick patients, in ICU patients who are admitted with AKI, admitted in ICU patients, so for prognosis of this can be tested. Next is cystatin C. So this you all know. Yes, cystatin C, it's been used now. So it is not a newer marker, but it is in use, right? So it's a non-glycosylated protein. As you can see, it's freely filtered, completely reabsorbed and metabolized, and it's not secreted. And what is its one advantage over creatinine is it's independent of muscle mass. And if you can see, you can calculate also EGFR, you can calculate using this cystatin C. So cystatin clearance also, the clearance test also we can do. And serum cystatin levels, the T half is very much less compared to that of the creatinine. That's what tells the use of the cystatin C, serum cystatin C in AKI. Okay, so this cystatin C is being used. So not just as serum cystatin C, it can also be used as in the clearance test, and not just that, even in EGFR. EGFR is a calculation, right? So we usually calculate EGFR using creatinine values, but we also have formulae for calculating EGFR with only cystatin values, serum cystatin values, or with both the creatinine and the cystatin values. So creatinine, cystatin values, including EGFR value, is comparatively more sensitive. Okay. And next is matrix metalloproteinases 7. That's an endopeptidase elevated in AKI. Urine matrix metalloproteinase is more useful than the serum one. And if you can see, if you want to understand about the tubular injury in FSGS, that is focused segmental glomerulosclerosis and minimal change disease. You may use MMP7 with cystatin C with retinol binding protein. So if you are checking all these three analytes, it is useful in the tubular to assess the tubular injury. So these are some of the novel biomarkers of AKI. All right. Next, we'll see the biomarkers of CKD. Again, there is